Hello and welcome to the Sunday Times Connect webinar in association with Sanofi Pasteur. I'm Joanne Joseph. Thank you so much for joining us today. So we're going to be addressing a topic that's hardly ever spoken about in the public domain, invasive meningococcal disease. Yet we may have a memory of perhaps being warned about contracting it in the past, or having heard about someone who did contract it, perhaps with some fatal consequences. It may be a rare disease, but contracting it can have really dire repercussions. And that's precisely why we're having this discussion today, just days before World Meningitis Day on the 24th of April. Now, the aim of this conversation is not to alarm you. What we want to do is give you a forum to hear from the experts on this subject, qualified medical experts who have years of experience in this field, but also to allow you to put your questions to them, your concerns to them, raise any issues you may have to get complete clarity on the issue of this, and particularly the vaccine treatment around this particular medical disease. And this, of course, we're hoping is going to help you to make better medical choices in terms of whether you ever find yourself in such a situation, or a member of the family or a friend does, and you are able to be that person with the knowledge in hand to be able to help them deal with it. I want to encourage you on that note to please make use of the live chat. It really is a wonderful facility that you can contact our speakers directly. I will put the questions to them on your behalf, and I encourage you to ask those pertinent questions, please, by using the live chat. We will, after having a little discussion with our two guests, give you a chance to have those questions aired, and ensure, please, if you are able to, although our guests are experts on both experts equally on the subject, I'd love you to be able to just signify for us exactly who it is that you would want to answer that question for you. So don't forget to make use of the live chat function. All right, so now you have the background to exactly why we are here today. Take a look at this for just a little bit more background. I hope that gives you a little bit more background as to our conversation today. Let me introduce you next to the exceptional women who are our guests today on this panel. We've got with us Dr. Nasiha Sufi. She's been in academia for 20 years, and she has several degrees in science and medicine. She's published a number of high-impact articles on infectious diseases. She's also contributed to the Oxford textbook of global public health. Dr. Sufi is currently head of medical at Sanofi Pasteur, South Africa. Welcome to you, Nasiha. Lovely to have you with us. Ms. Lee Baker is the owner of Amayeza Information Services, and she has 34 years of experience in medicines information. She's edited a number of books. She's also president of the South African Society of Travel Medicine and a member of the South African Malaria Elimination Committee. So Lee regularly presents talks and vaccine training to nurses and other healthcare professionals, and she's going to be talking us through this today. Welcome to you both, Nasiha and Lee. Nasiha, I'm going to ask you to kick off by just taking us through the significance of this discussion.
Thank you so much, Joanne. So invasive meningococcal disease is one of the most understated infections. Yet, this bacterial infection could leave an individual permanently disabled, if not dead, within hours of exposure to the bacteria. Now, the disease is not easily diagnosed because clinical symptoms are often ambiguous and treatment is not a guarantee. So the only option we have as parents to secure our children, to secure ourselves, as healthcare professionals to secure our patients really is prevention, that is vaccination. Now, as South African citizens, we are incredibly privileged and fortunate to have access to a best-in-class vaccine that is available to patients in the private sector and is incredibly effective in preventing the illness. So that is why we've gathered today really to discuss this potentially fatal infection and to generate awareness around invasive meningococcal disease.
All right, fantastic, Nasiha. Thank you for that. And thank you for also just providing the blueprint for what is going to be our more detailed conversation now as we move into this discussion with you and Lee. Lee, I'm going to start off with a really simple question at this point, because the name of this disease itself is such a tongue twister. What exactly is IMD?
Okay, IMD is invasive meningococcal disease. And invasive means that it penetrates areas that are normally sterile sites in our body. So, for example, in the brain, in the meninges. And that's where one of the most common sites for the invasive meningococcal disease is, causing a meningitis, which is what we know that has some devastating effects, as Nasiha has mentioned.
So Nasiha, just expand on this more, because you alluded to it earlier. How prevalent is IMD?
So in the country, we have an incidence rate of less than 2 per 100,000. That means for every 100,000 people, less than 2 become infected. In 2019, we had a frequency of about 80 to 100 individuals in the country who became infected. However, I would like to draw caution in terms of how we interpret these numbers. It's very possible that we are underestimating the true burden or prevalence of invasive meningococcal disease in the country, simply because South Africa does not have the resources as we have in first world countries to be able to catch each and every case. Now, whilst this disease is you would say it's rare, at the same time, a single infection is incredibly devastating.
And of course, a moment ago, Lee, Nasiha mentioned that this IMD is easily mistaken for other diseases. What is it usually mistaken for? And how does one go about making an accurate diagnosis?
So it's very difficult initially, Joanne, because the initial symptoms are, as you said, non-specific. So they're actually like flu-like symptoms. And they can be mistaken for malaria, for example, and even now for COVID-type infections. And the problem with meningococcal infections is that from the time of the first infection until they are actually in a coma or can die can be a very short period of time. It can be as little as 24 hours. And the younger the person is who's contracted the infection, the shorter that period of time. So if we look in the first couple of hours, the type of symptoms that you get would be fever, irritability, maybe some nausea. Vomiting is then getting onto sort of more severe disease. They're drowsy, they can have poor appetite, and general aches and pains. And if you look at anything like flu, like hepatitis A, like I said, malaria, or even COVID, they can all be attributed with those symptoms. So that's one of the difficulties with this, is that we really need to identify it and diagnose it as early as possible so that we can start treating it adequately, because as Nasia has mentioned, even treating is not necessarily going to help them. And I think there are still up to 10% of them who die even when they're getting adequate treatment. And so it's really quite difficult in those early stages. So you have to be very alert and, and suspect something like that. If you look at some of the others that I've mentioned, like influenza, for example, you're not likely to die in the first 28 hours or 24 hours of influenza. Even malaria, in the early symptoms of malaria, not likely to die of it. So one of the things you have to suspect, because of its short time period, is meningococcal infection.
But Nasia, this must put you under incredible pressure as medical professionals to be able to pinpoint the cause of the symptoms a patient may be experiencing. What sort of technology exists to make sure that you're aiming at treating the right disease almost from the word go as a medical professional?
So, Joanne, this is difficult. From the word go, the disease has you on your toes, because in the early hours of infection, as Lee had stated, it's so easy to send the patient home thinking that the patient is just suffering from an upper respiratory tract infection like the flu. So in the early hours of infection, very often patients are sent home with a script, to treat a respiratory infection. But it's only hours later, 10, 15 hours later, when the patient starts presenting with the more classical signs and symptoms of a meningitis, like the stiff neck, a throbbing headache, or a fear to look into light. That's only when the healthcare professional is then able to connect the dots and say, you know what? Actually, I'm suspecting this might be meningococcal meningitis. And that's the trigger for the doctor then to utilize whatever lab technologies are available. So for instance, he may want to do a lumbar puncture and pull some CSF, do a serology test, and in this way send that off to the lab for testing. It's only when we do a lab test can we be close to 100% sure that it is indeed a Neisseria meningitidis-associated meningococcal meningitis.
Right. So that the thought of that is really quite intimidating. But Lee, tell me, who is most at risk?
So there are certain groups that are at risk factors, but I need to say up front, anybody can get it. Okay. So the risk factors are particularly if you have no antibodies or an immune system that can't fight it. So your tiny babies are a good example. People who've got immunodeficient diseases, people who have had their spleen removed, for example, are at higher risk of contracting these infections. But then there are people, because of what they do or where they go, they are at risk. So we talk about people who attend big gatherings, but particularly hush, they are at greater risk because it spreads, although it's not a type of infection that is as contagious as measles, for example. It spreads in areas of crowded groups. So wherever you have crowding, you are likely to. And then people who smoke are at greater risk of contracting meningococcal infections. So in our populations, up to 10% can be carrying the bacteria in the back of the nasopharynx, or at the back of the nasal area. And we are carriers, but we don't get sick. But then when we get together, we can spread it. And then there may be somebody who actually will have one or other reasons for being at risk, and they will then contract it. So we also talk about groups like your university students, your first year university students, or your military, who are going to stay in hostels and things like that, who are then also at risk of contracting it. But as I said up front, anybody can actually contract it.
That's quite a prospect. Nasia, I'm going to ask you to just guide me here. Lee has intimated to us how important it is to catch it early, catch this disease early. What happens if it's not caught early enough?
So, Joanne, unfortunately, if a patient is not diagnosed in time, this means we've allowed the bacteria to spread in the body. So from the upper respiratory tract, it can spread into the blood, and as Lee had pointed out, can enter into the brain and spread to the meninges. So if we allow for this to happen, once it reaches that point where it's in the blood, it's in the meninges, it's incredibly difficult to turn around. And most likely this patient then is going to be left with permanent disabilities or die from the infection.
That's very sad prospect indeed, if it can be prevented. Just in terms of ensuring that we are speaking in layman's terms, what exactly are the meninges, Nasia?
So the meninges are actually a thin covering of the brain. And it basically acts as a buffer between our actual brain tissue and our skull cavity. So it just acts as a buffer, protecting our brain tissue from injury against our skull cavity. So when this meninges, this covering of the brain becomes infected, you can imagine, it's in contact with the entire brain. And so that infection spreads very quickly.
And Lee, what are the long-term consequences for patients who contract IMD, those who survive, of course?
Okay, well, as Nasia said, they're usually left with some form of sequelae or some after effect. So the most common one for meningitis would be deafness or mental retardation. But when it gets into the blood and you get a blood infection, and in this case, we call it a meningococcaemia, then they can actually lose a limb. And I have some pictures that I can show you what the after effects are. And it's estimated that about 20% of people who contract these infections will be left with one of these after effects. And for meningococcaemia, up to 40% will actually die. They won't survive. So this, as Nasia said, this is actually a deadly disease. You may not have thousands of cases, but when you do have a case, it really is very severe.
I think for medical experts like yourselves, it's probably easier to visualize exactly what that looks like on a most human level, walking into a ward where you see children or the elderly or the immunocompromised who are lying in a hospital bed suffering from it. I take it, Nasia, that is quite an alarming sight.
Absolutely, Joanne. In fact, it's an incredibly traumatic experience for a healthcare provider, himself or herself, to manage. It's one of those cases as a healthcare professional that if you've ever treated one, you will remember that case for the rest of your career. So it's incredibly devastating.
Yeah, and one can only imagine what it's like for family members and so forth. So the good news, as we know, is that you can be vaccinated against it. But before we get there, I want Lee to give us a slightly more visual representation of what this looks like, how the symptoms present and so forth. Lee, won't you just talk us through these physical manifestations you'd be seeing in the kind of patients we're speaking about, please?
Sure, if we can put up slide 19 and slide 21, I can show you. Okay, so if you look at these pictures, the person lying in the bed has got meningococcaemia, and that's where you can see where actually the tissue is dying, and the chances are that this patient, if he survives, will lose a limb. If you look at the little picture of the little child, you can see what the consequences are of having meningococcaemia, whereas this little child, when it was a baby, contracted meningococcal infections and actually lost part of all 4 limbs. If you go to slide 21 now. Okay, so the legs here where you see these blood marks, that is what we call a petechial rash. And when you see that, you know that the patient is in big trouble. And this is very specific to meningococcal infections. And it actually isn't a rash, it's bleeding under the skin. But then the other two pictures you can see once again where the likelihood of losing the limbs are because of the meningococcemia. So you can see, as Nasir said, if you've treated a patient with it, you won't forget it because it's absolutely devastating, especially in your little babies, where we see most of our cases.
Lee, I want to bring up the issue of vaccine hesitancy, because we've seen a resurgence of this in recent times, particularly in relation to the COVID vaccine, but it's been around for a long time, where people, a lot of misinformation has been spread, a lot of fake news does the rounds regularly. And you've got a community of people who simply will not touch vaccines with a 10-foot pole because of all the misinformation around this issue. I want you to please just talk us through the myths around the vaccination, the sort of popular examples of fake news around vaccinations that regularly do the rounds, please, Lee.
Sure, Joanne. So in 2019, the World Health Organization acknowledged that vaccine hesitancy is one of the top 10 threats against global health. So they've acknowledged that it's a big problem. And although there are many causes and many reasons for vaccine hesitancy, these myths are really the greatest problem. And they are spread mainly through social media, which makes it extremely difficult. So if they'll put up slide 7 for me. Okay, so this is a list of the most common myths, okay, that have been around for ages. There are a few others regarding COVID particularly that I can mention, but I'd like to really speak to these ones. So the most common one is MMR and autism. So MMR is a measles, mumps, and rubella combination vaccine. And it has been blamed for causing autism. So, and this has been around for many years. So in 1995, a doctor called Andrew Wakefield in the United Kingdom published some data, and he had done a study on 12 children, and he showed that some of them had measles virus in their gastrointestinal tract. And he then made the claim that this combination vaccine could cause autism. But when they and it was published in a very good journal, medical journal, but then when they investigated it more clearly, they found out that he actually had a conflict of interest. For example, he was being paid by lawyers to fight for a case. He also was manufacturing his own, or a company that was manufacturing his own vaccine that he wanted to push. He hadn't got ethics approval for any of the study that he did. He had taken blood from children without getting ethics approval. And eventually, in 2004, they claimed that the research was unethical, and they retracted both the information and the study from the journal. But this did caused quite a lot of stir at the time, and a lot of the people at the World Health Organization and in other groups like the FDA said we need to investigate this to see if there is any chance that it could be caused. So many studies were then set up to look at it throughout the world, and hundreds and thousands of children were investigated, and they showed that it does not cause autism at all. In fact, in some of the countries where they don't use MMR, the number of cases of autism is increasing. And so what they have shown now is that there is some genetic disposition to autism in the fetal development, and it actually has nothing to do with the vaccines at all. So this gentleman, Andrew Wakefield, had his license to practice in the UK revoked in 2010. But he is in the United States, and he is actually still practicing. But the damage that he has done is irrefutable. I mean, there have been outbreaks of measles. In fact, the United Kingdom has lost their measles-free status due to this. In many countries, they have seen hundreds of thousands of cases of measles, all come back due to this myth of the MMR vaccine causing autism. The next one that's also very popular is the use of thimerosal in vaccines. So thimerosal is a mercury-based preservative that was used in many vaccines in the early stages, because many of our vaccines were multiple dose vaccines. And you have to put a preservative into a multiple dose vaccine to ensure sterility. Otherwise, you would have to throw it away as soon as you opened it. And thimerosal was the most commonly used one. But when somebody said, look, we know that a very small amount is used in these vaccines, but maybe because babies are getting more than one vaccine, it could accumulate and cause damage. So they investigated, but at the same time, they asked companies to, if they could, to remove the thimerosal. Most of the vaccines that we get in private sector now are single-dose vaccines, so they don't need a preservative. But also the myth was that it was the thimerosal in the MMR that was causing the problem. Now, MMR is a live vaccine, and you can't put a preservative in a live vaccine because you'd actually kill it, and it wouldn't work. So there never has been any preservative. There are traces of antibiotics, but there's never been a preservative. But you need to understand what thimerosal actually is to realize that there isn't a problem. And thimerosal is ethyl mercury. And ethyl mercury, when it gets into the body, is just excreted. Doesn't accumulate in the cells at all. Whereas the other type, called methyl mercury, can accumulate in the body. And so in some of our dental fillings, there used to be methyl mercury. So some people may have heard the horror stories that it can cause mental retardation. Some fish has very high levels of methyl mercury in it. But this is not what was in the vaccines. So thimerosal does not cause any problem, but most of our products don't have it in any way. Too many vaccines overload the immune system. Well, when a newborn baby is born, it's exposed to so many different what we call antigens, or different proteins in the world, and they are able to cope with that. So the few extra that you put in with vaccines doesn't do anything to the baby. Aluminium was then decided that maybe aluminium can cause it, because you've heard that if you cook in aluminium pots, you're going to get brain damage, things like that. And many of our vaccines do have aluminium in it, because they used it to increase the efficacy of the vaccine without having to increase the dose itself. The amount of aluminium in the vaccine is a minute amount. Baby gets much more in breast milk and much more in formula milk. So that has been shown not to work at all. And then there were, for many years, if your baby needed a measles vaccine, you weren't allowed to have it unless you had given the baby egg to eat, because they were worried about egg allergies. And the reason for this is that the measles virus for the vaccine is grown in fertilized eggs. It is then extracted from the egg and made into a vaccine. And it doesn't actually have any tissue left from the egg at all. So many studies have been done now to show that your child may have an egg allergy, but they can have the vaccine. They can also be allergic to the vaccine, but it could be the gelatin in the vaccine, not the, definitely not the egg at all. So children allergic to egg can quite safely have the measles or the MMR vaccines now. Vaccines given too early, the immune system of a newborn baby can work very well. That's how it fights off all the other things it's exposed to. But it can't fight off many of the actual infections. So especially meningococcal, for example, doesn't have the ability at a young age to fight off meningococcal infections. And that's why it's very important to give vaccines to the young children, because the vaccines enable their immune systems to work so that they can prevent getting the infection. The last one is vaccines are made from fetal tissue. So the anti-vaxxers are very keen on saying, you know, there's fetal tissue. They used aborted fetuses to make vaccines from. So the story is partially true. There are some virus. In order to make a vaccine that's from a virus, you have to grow the virus in some living cell. And many years ago, they found, for example, that the rubella or the German measles virus grows exceptionally well in an aborted fetus tissue. And it was from an abortive fecal that had happened in the 1970s. And now they don't keep killing a baby every time they need to make the vaccine. They use those same cells in the laboratory, and they just grow those cells in the laboratory now. And that brings me to the COVID vaccines. One of the myths about the COVID vaccines is similar, that the virus is grown in fetal tissue. It's the same thing. It's grown in something that did derive from fetal tissue, but it's no longer from the fetal tissue. It's actually in a laboratory now. I don't know what else there is. COVID, there's, you know, that the 5G is putting something into your into your bodies, and so they can monitor everything about you. These are really just science fiction. There's nothing real about them at all.
So Lee, thank you so much for taking us through all of those myths, and it's important to have an awareness of what they are so that we can bust them, essentially. And of course, this podcast will be available later on. This discussion will be available as a podcast on the website, so you can actually go back if you need to consult this again, because you're speaking to people who do form that group, who are hesitant about vaccines or lack the answers. Maybe you want to share a link with them. It's important, very important part of the discussion that we designate what Lee has just spoken about as falling into the realm of fake news, so that we can address the issue of the importance of vaccines. And Nasia, I want to bring you back into the conversation here. So we now know that there are vaccines available to address IMD. Tell me what is available on the market now to prevent IMD?
So we do have a best-in-class product available to South African citizens. It's available in the private sector. It's a meningococcal conjugate vaccine. So if you as a parent would like to get the vaccine firstly for yourself as well as for your children, all you need to do is speak to your healthcare professional. So you would speak to your general practitioner or your pediatrician to ask them to write a script for you for this meningitis vaccine. And thereafter, the vaccine is very easily administered. Depending on the group of a high-risk patient that you may potentially fall into. So for example, if you want to look at vaccinating your child and you have a baby who's less than 2 years of age, then in this case, your child will require 2 doses of the vaccine, at least 3 months apart. If you have children older than 2 years, they would just require a single shot. If, for example, you yourself are an HIV positive patient, for instance, then you would get 2 shots of the vaccine. So it's a conversation which you need to have with your healthcare professional, and your healthcare professional will then guide you on the vaccine and the number of doses you would require in your individual case.
See, there's something I don't understand. I mean, given the background that you and Lee have sketched for us now and how serious this disease is, why are we not getting a mandatory vaccination for every baby in the country, or perhaps every adult that falls into a group that's particularly susceptible?
You know, Joanne, this is a very, very good question, but it is also an incredibly controversial topic. So there are some countries that have mandated vaccination, but South Africa is very much a democratic nation, and we are a young democracy. So unfortunately, vaccination cannot be made mandatory. The other reason as to why vaccination is not mandatory in South Africa, apart from our democratic status, is also because there may be a very tiny group, a small group of individuals who could be allergic to some of the vaccine ingredients, and they may not be able to get the vaccine. This is a very small fraction of the population, but it is more for these reasons as to why vaccination is not mandatory in South Africa.
So what vaccination programs linked to IMD are actually available to the public, Nasiha?
So the vaccine which we use to protect against invasive meningococcal disease is not a part of the public program, meaning it's not part of the expanded program of immunization schedule. It's not part of that Road to Health booklet which you get when you give birth to your child. So the moment a mom gives birth and the child is seen by a pediatrician or the nursing sister, mom is given a timetable of the different vaccines which the child needs to get. Now, unfortunately, if mom is seeing a government facility, the meningococcal conjugate vaccine will not be reflected on that chart, simply because it is not available free of charge at government facilities. The parent would have to pay for the vaccine themselves. But what mom could do, if mom is convinced that yes, indeed, this is an important vaccine for my child to get, is to speak to their healthcare professional and say, I've heard about this meningococcal conjugate vaccine. Can you inform me? Can you provide me with additional details, please? And could you please provide me with a script for the vaccine? And once they get the script, they can then go off to their healthcare professional to have the vaccine administered.
So Lee, it's a bit of a complicated process here, and I see the onus is very much on the parent or caregiver if their child, for example, is not born in a private medical facility, to go and, first of all, internalize the information about why this vaccine is a good idea for the child to take, and secondly, the process of acquiring a script and ensuring that a certain number of doses required are given. Lee?
Yeah, so that is true, but we do have some programs for older children. So, for example, university students, we've done some programs at the universities to try and increase awareness. And I must say that in universities where there has been a case, like, for example, Potchefstroom University a couple of years ago, they are very open to hearing more about it and administering the vaccines. So it's really by increasing awareness that we're going to increase the number of people who are prone to or at risk to actually get it. As I mentioned, people going to Hajj are particularly high risk because of them being in close contact with so many people, and it's mandatory for anyone going to Hajj to actually have the vaccine. So travel clinics in particular will make those people aware that if they are going, they need to have it. There's an area in Africa called the Meningitis belt, which is up in the top part of Africa. And it stretches from basically Senegal to Ethiopia. And this is an area that has regular epidemics of meningitis. And so any traveler going there would be advised to have the vaccine as well. So it really is a case, Joanna, of increasing awareness wherever we can, to make people who are susceptible realize that if they can afford it, that's what they should be doing. For our babies, especially those who are going to a creche from a very young age, we should emphasize the need to have it if they can. As Nasia said, it's not part of our EPI. And once again, that comes down to cost, I think, in that our government only has X amount of money to spend on vaccines. And so they look at the burden of disease in a country and will then focus on those diseases. If we had unlimited amount of money in our country, which would be wonderful, then I think the people on the EPI would be offered just about all the vaccines that we have available.
What does EPI stand for, Lee? Just remind us, please.
Expanded Program on Immunization.
All right,
So
and that
this
is a government-run program.
Yeah, so this is what the government has decided are the most important vaccines that every child in the country should be offered. And as Nasia said, they're offered free of charge in the public sector.
Right. But Lee, you mentioned cost there, and to see how, I mean, everybody's probably asking the question, everyone who hasn't had the vaccine or hasn't had their kids vaccinated yet, what does it cost? Is it cost prohibitive?
Okay, so Nasia will answer. I'm not sure of the actual price.
Yes. Nasia, go ahead.
Please feel free as well, Lee, at any time, to cut in. Perfectly okay with me. So the vaccine costs about 725 Rand per dose, Joanne. So for some, that may be quite cost intensive.
Absolutely, absolutely. And of course, you mentioned earlier, Nasiha, that if for most people, it's not just going to be one dose, right? It's got to be a series of doses, and presumably you've got to stick very strictly to that vaccine schedule.
Absolutely. Yes, absolutely, Joanne. So it's 725 Rands for a single dose. And some groups of individuals will require 2 doses as well as a booster shot every 5 years. So yes, it can be cost prohibitive for some individuals who may not be able to afford the vaccine.
Just doing the maths off the top of my head, which I must admit to you is not my strong point, but I'm looking at the kind of slides that Lee has shown us in terms of the symptoms, the very advanced treatment that is required. Surely it would be in government's interests to stave off this potentially devastating disease from the start by offering this as a mandatory vaccine instead of having to treat large numbers of people who've contracted the disease later on.
So to your point, Joanne, absolutely. The cost of a single dose of the vaccine is 725 Rands. But if you were to compare that to the cost of managing a patient who has now become infected with invasive meningococcal disease, who needs to be managed at hospital, who's going to be admitted to ICU and stay on for a very long time. And then the long-term costs associated with potentially managing disabilities are astronomical as compared to a 725 Rand vaccine. So certainly you've raised a critical point. It is something which we need to in earnest consider. In terms of the public sector mandatory vaccination, as I've mentioned, South Africa being a democracy and some individuals may be having allergies to the vaccine, mandatory vaccination may not be a possibility. Considering the cost of having each and every individual in the country vaccinated with the meningococcal conjugate vaccine may likely also not be a probability for government to fund, considering we are a middle income country. But at least we should, and to your point, Joanne, consider providing these vaccines at least to our high-risk patients.
Right. I mean, we've seen the effects of COVID in this country, Lee. I don't imagine that we're looking at the same scale of outbreaks and that kind of thing. But you did mention the Hajj pilgrimage as one example. You mentioned universities as another example of where large groups of people are gathering. Are we ever at risk of an outbreak, Lee, if we don't, if more of us aren't vaccinated, if perhaps we don't develop herd immunity as a result of being vaccinated for IMD?
Okay, so we are a very long way off herd immunity, but there are outbreaks. We fortunately have not had huge outbreaks in the last 20, 30 years, but we have had small outbreaks. The majority of the outbreaks have been in creches. And the other cases that we have that cause great consternation, like in a university, they are one-off. They don't spread. As I said, it's not nearly as infectious as something like measles. So it doesn't spread like wildfire through a population. It really spreads through close contact. And if anybody hasn't been vaccinated and comes in close contact with somebody, then the ideal thing for them to do is to actually have an antibiotic, a specific antibiotic, at the time, preferably within 24 hours of being in contact. Because what this does is it stops that nasopharyngeal carriage and can stop it. In addition, they can have the vaccine, but the vaccine takes about 10 days to be effective. And the incubation period of meningococcal infections is 3 to 4 days. So quite likely, if you, for example, have been in contact with somebody and they were diagnosed today with a meningococcal infection, if you had the vaccine today, you may not be protected in time. And that's why the antibiotic is critically important for anybody who's been in contact with a case to have that straight away. So in an ideal world, as Nasir has mentioned, we should all be vaccinated, and then we wouldn't have to worry. We wouldn't have outbreaks, and we would be protected. But as I said, fortunately, we haven't had major outbreaks in our country for many years.
Thank you for that, Lee. I want to get into our Q&A section now based on the questions that have come through on our live chat. And I want to thank you for sending those questions through. Please do keep sending them through. Just specify who you would like to answer them, whether it's Nasir or Lee. And some of them are very interesting. This is one of the first that's come through. And Nasir, Lee has spoken about this already, but I think it's very important to draw attention to it because it's a very specific question. Can a post-meningitis client develop mental instability and visual impairment? Nasir?
Absolutely, Joanne. So if a patient is exposed to Neisseria meningitidis and has now invasive meningococcal disease, meaning they are now presenting with meningococcal meningitis, or even, meningococcal septicemia, for instance, there are many long-term sequelae, and especially with regards to meningitis, as the person has postulated in their question. Absolutely, if the patient has been diagnosed with meningitis, the likelihood of them suffering a mental retardation is great.
And Lee, just to be clear on this, is this a temporary state in terms of these symptoms that Nasir is speaking about, or is there lifelong impairment from this?
No, it's usually lifelong impairments because of the damage that is done. The damage is permanent. And as I mentioned, up to 20% of people who have a meningococcal infection will be left with one of these after effects.
All right. So I mean, that certainly draws attention to the importance of getting vaccinated, of dealing with the problem immediately once it is diagnosed. A question for you, Nasir. Dr. Sufi, please, could you explain the difference between bacterial and viral infections, and are they treated the same way?
This is also a good question, Joanne. And Lee, also please feel free to come in here. So when it comes to meningitis, there are two categories. You get viral meningitis, as the individual has rightly pointed out, and you get the bacterial meningitis. The one we are discussing today is the bacterial meningitis. And usually the meningitis, which is caused by bacteria, is a lot more aggressive and fatal, where often viral meningitis may be milder. So the one we're discussing today, meningococcal meningitis, which is caused by Neisseria meningitidis, is the more serious, aggressive bacterial infection.
All right. And just that question about in terms of treatment, how does the treatment differ between the two? Lee, would you like to answer that?
Yeah, I can answer that. So bacterial infections are treated by antibiotics, and they've got to be antibiotics that can actually pass through the blood-brain barrier and work in the brain, and not all antibiotics do that, so they're very specific. You also get different types of bacterial meningitis. So as Nasir has mentioned, the meningococcal one, or the Neisseria meningitidis, is the rapidly fatal one. But pneumococcal infections can also cause meningitis. TB can cause meningitis as well. And so these are also bacterial meningitis, and they get treated very specifically with antibiotics that work on those bacteria itself. Viral meningitis would have to be treated with an antiviral, not an antibiotic. And some of the viral meningitis that don't have an antivirus that works against it. So it would depend entirely on what it is. But if we look at the whole picture of meningitis, so the word meningitis means that the meninges have been inflamed. And then the cause would be either bacterial or viral. And so they treat it as a whole symptomatically the same way. So specifically, the bacteria would be treated with an antibiotic, and the viral would be treated with an antiviral if there was one that could be used. But just generally, symptomatically, they would be treated the same way.
While we're talking about the issue of vaccines and the ingredients, and I know you pointed out earlier that it's a very small percentage of people who are actually affected by some of the ingredients that a vaccine contains. But one of our viewers asks, could you please list ingredients of this vaccine that could trigger an allergic reaction in a rare case?
Okay. Nasia, I'm not too sure what preservative is used. Do you know the preservative that is used? I think it's paraben. I will look it up quickly, Joanne, and then I will tell you what it is. But most of these vaccines have very few ingredients that can make them cause allergies. But you can be allergic to the actual vaccine. Okay. So we talk about that as an anaphylactic reaction in particular, as a specific reaction between a patient and a vaccine. So you wouldn't say, for example, that the meningococcal vaccine causes a lot of allergies or a lot of anaphylaxis. You could take it and not have any effect, but I could take it and I would have it, because it's a relationship between a person and the vaccine that causes it. So we don't talk about these vaccines cause anaphylaxis, these don't. As I said, it's a specific reaction between a patient and person. So I will quickly look up and tell you what it is.
Thank you. Thank you. Nasia, would you want to add anything to what Lee has said there?
Yes, so absolutely. So Lee, and please also feel free to continue to add. So yes, for instance, the vaccine may have sodium chloride, dibasic phosphate, anhydrous, these sorts of ingredients. Some of our vaccines may also have antibiotics as well in them. And the list can be quite extensive. So what I would suggest is that if you do have any allergies, what I would recommend is that you speak to your healthcare professional and be upfront about it to say, I have these allergies, but I would like to get the meningococcal conjugate vaccine. With the vaccine, would I be eligible to get the vaccine? And then the healthcare professional will do a risk-benefit analysis and advise accordingly. So there are some ingredients, as I have listed, and if you are allergic to them, likely you would not be eligible for the vaccine, but I still strongly recommend that you have the discussion with your healthcare professional to do a risk-benefit analysis and map a way forward.
So Nasiha, on that note, I mean, we're talking specifically about allergies, but what about people with particular comorbidities? So, for example, if a vaccine, for argument's sake, has sodium chloride in it, and you've got a hypertensive patient, can you advise that patient with high blood pressure to take this vaccine safely?
Absolutely, Joanne. So someone with high blood pressure is not contraindicated to get Menatra. They may certainly get the vaccine. It's not one of our contraindications, simply because sodium chloride, the amount contained in the vaccine is minimal. So it would not have a major effect on the patient's blood pressure. However, if there are other contraindications to the vaccine, for example, say a patient had received a vaccine that contains one of the ingredients that are also included in the meningococcal conjugate vaccine, and following that had a major reaction, in that case, I would caution against. But again, it's a very small proportion of individuals who have allergies to the vaccine.
All right, thank you for that, Nasia. Lee, have your investigations revealed any further details?
It's exactly what Nasia mentioned. It's the sodium chloride and the dibasic sodium And though there is very, very, very unlikely going to be an allergy to those two ingredients. Okay.
All right.
So the type of ingredients that can cause allergies are, for example, gelatin. And gelatin is in the measles vaccine. And so that could cause an anaphylactic reaction. But as I said, you can actually get an anaphylactic reaction to the vaccine itself, not specifically one of the ingredients in it.
All right, that's good to know. A question, Nasiha, about the 5-year booster. One of our viewers is asking, is the 5-year booster only for people who are HIV positive?
No. So, Joanne, there are certain high-risk groups who will be vaccinated differently. So what I mean here is that the meningococcal conjugate vaccine is indicated from 9 months of age until 55 years of age. So individuals between 9 months of age and 2 years of age, they require 2 doses at least 3 months apart. Okay? And individuals from 2 years of age and above require a single full 0.5 ml dose. But there are some exceptions. If a patient, for instance, is immunocompromised, maybe asplenic, so for instance, if they've had their spleen removed, if a patient is HIV positive, if you are a lab tech that's working in a laboratory setting where on a daily basis you are investigating Neisseria meningitidis, if you are a miner who works in mines in congested settings where these bacterial infections can very easily spread, if you are a tertiary student, then you will fall under some of these high-risk groups, and the list is quite extensive. If you fall under one of these high-risk groups, take, for example, if you're the asplenic patient, then you would need to get 2 doses at least 3 months apart, and then a booster shot every 5 years.
All right, I hope that answers the question for one of our viewers who had that question about high-risk individuals. A quick one from you, Lee. If an elderly patient older than 45 has not been vaccinated with PVC 13 and Menactra, what will the preferred regime be? That's a very specific question.
Okay. So they could have them on the same day if they are healthy people. The only time that we would have an issue is if they had their spleen removed. Then the idea is that they must have their pneumococcal vaccines first. And once they've finished that, a month later, they can have their meningococcal one. But we only recommend the pneumococcal vaccine to people who are actually at high risk. We don't recommend that everybody, once they're over 65 years of age, they should get a dose. But otherwise, a healthy 45-year-old is not recommended to get a pneumococcal vaccine.
All right. And one of our viewers is checking, Lee, that the meningitis vaccine is available from a travel clinic.
Yes, it is. You can get it from a travel clinic because the travel doctor would be able to write a script for you at the time.
All right, thank you, Lee. Nasiha, we're getting to the end of this discussion, and I would like you to just wrap this up for us, because there's a lot of information we've shared with our viewers today, but there's ultimately one message that you want to get out there about the importance of this vaccine and the importance of actually eradicating this disease, hopefully in the future. What is the crux of that message, Nasiha?
Thank you, Joanne. So I'd just like to stress, to reiterate, that invasive meningococcal disease is incredibly understated. It is a fast progressing, aggressive bacterial infection. This infection is not easy to recognize. The early symptoms are ambiguous. It's incredibly difficult to diagnose. And treatment is not a guarantee. Do not play Russian roulette with your life, with your children's life. The only tool we have to fully secure ourselves and our children or our patients really is vaccination. So do not hesitate. Try as best as possible to ensure that you, your families, and your patients are fully vaccinated against this potentially fatal bacterial infection.
Nasia, thank you so much for wrapping up the discussion for us. And I want to thank you and Lee for your expertise in this regard, for so clearly deconstructing and helping us comprehend what could have been actually quite a difficult discussion to have. But I think that the messages are there are very clear. The next steps that you need to take are very clear as well. So thank you very much. Nasia Sufi, the doctor who's joined us here from Sanofi to be able to talk us through this. Lee Baker, thank you so much for your expertise and your 34 years of experience that certainly come to the fore in this discussion with you today. And that is where we wrap it up for today. I want to thank the Sunday Times for partnering with Sanofi on this important conversation. And I really hope that wherever you were watching from today, you were able to gain some real insight into IMD. All the information our two experts were able to bring you will impact your thinking about this disease. And perhaps it wasn't on your radar at all. Certainly wasn't on mine before this webinar was announced. But of course, it's something that we need to talk about, need to educate ourselves about, need to educate our families about. And of course, Lee's discussion with us, in fact, about the fake news and the myths and propaganda that have been doing the rounds for so many decades is just as relevant to all the other conversations we're currently having in our society about COVID as well. So I hope that this impact is much wider than just a conversation about IMD. But let's put that at the forefront today. Think about it hard. Think about how you can make it work for you and impact your thinking, especially in regard to the medical and health decisions you make around protecting yourself and your family. That is where we will leave it for today. From me, Joanne Joseph, and the team that joined you today, keep safe and take care. Bye-bye.
Thank you. Bye.